thank you to the sponsors, both AstraZeneca and Intas. And we have a very packed schedule. So without much ado, I will ask the first Dr. Ullas Batra to start his first talk. Dr. Ullas Batra needs no introduction. He is a senior medical oncologist from Rajiv Gandhi Cancer Institute in Delhi. So over to Ullas, sir.
Okay. Can I have the slides, the first slide on over here? So first of all, good evening, everyone. And I really hope and pray and wish that everybody is safe. I mean, the only thing we all miss talking about lung cancer, debating with Senthil, listening to Kumar, listening to Sahu, Ahmed, Dr. Shyam Agarwal. But one thing which is very important is, we want everybody to safe. So stay safe, stay at home whenever you can. And otherwise, we are all under Hippocratic oath. We have to work. So my topic of my talk is basically obtaining tissue and diagnosis of suspected patients with lung cancer. Next slide, please. So my disclosures, next slide. I'm a Delhiite, and ever since we have been the one guy which hasn't prepared for the COVID mask thing since November 2019. So November 2019, it was the on and off, and the pollution in Delhi which made us wear masks. Then it was the fog which made us wear masks. Next one, and then from March, April, it has been the COVID which is making us wear masks. So Delhi is one state which ideally in wearing masks, at least we have been able to we were prepared for COVID. But that's only in wearing masks that we will prepare for COVID. Because if you see the numbers, I am just next to Dr. Kumar. That is Mumbai. Delhi is next to Mumbai, and I really hope that everybody gets down to zero together. We all go to Goa once again. Okay, next one. So why are we even talking about next one? Because see, you look at all the children over here. They're all the babies. They're all beautiful babies over here. But all these babies, as you see, are actually different. So like all these babies are different, next one, we actually know that lung cancer is the poster child of precision medicine, next one. And the key to personalized medicine is the precision in diagnosis. So if you don't have a good diagnosis, you will never be able to treat anyone well. We just had a discussion regarding, whether which test, which one to order. Similarly, in lung cancer, you need the diagnosis to be there to actually having a personalized medicine. Next one. So the outline of my talk, I've split my talk into two. One is about obtaining tissue, and the next one is about making diagnosis. So let's talk about obtaining tissue. So next one, yeah, next one. So there is, there are a lot of time people ask us a question whether we should get tissue from the primary tumor site or from the metastatic tumor site. It doesn't make a difference. It doesn't make a difference whether you take it from the primary tumor site or from the metastatic. The choice of the site depends on the ease of access, safety, and likely tissue yield. So if you have a supraclavicular lymph node, please take a biopsy from there. If you have a pleural effusion, do a cell block from there. Next one. So acceptable sites of tissue acquisition include CT-guided lung biopsy, bronchoscopy, pleural effusion cytology, and cell block, a lymph node biopsy, a thoracoscopic or a VATS pleural biopsy. These are all yes. What is no is actually, next one, is just the sites that needs to be preferably avoided are bone biopsies. So let us say you have a lesion in the bone. If you do a bone biopsy, you'll have to decalcify it. And if you decalcify it, you will never get the DNA out of it, and you may not be able to perform the molecular test. So soft tissue component, yes. Bone biopsy, maybe no. Pleural fit cytology only, without cell block, just as this thing positive malignant cells, not done. And definitely FNAC alone is not a standard procedure at all. You need a biopsy. Next one. So that's basically brings about me from diagnosis of lung cancer. And I've been reading a lot of books, so I've been reading a lot of preparing for my next debate with the Kumar, Senthil, and Sahu. And, I am trying to know my enemies, like we all are trying to know more about coronavirus. They're my friends, by the way. They're not my enemy. They're my co-debaters. So we should know our enemy, and that is what will help us in defeating that. And please read this book, Sun Tzu, It's the Art of War. It's a fantastic book. Dr. Shyam, you can read this book anyway you are sleepless in the nights. Next one. So the goals of lung cancer diagnosis in 2020 basically is should have the histology confirmed by a minimal IHC. Then you should go for molecular testing. Next one. So the goals of testing in lung cancer in 2025 would be, next one, that to do more and more with less and less until eventually you can do everything with nothing. I mean, that is what our ultimately goal in 2025 is going to be, so that we can just, we'll just have an FNAC, take out the DNA or RNA from it and do an NGS for everyone. That is where Kumar wants us to be in 2025. And hopefully we will come to a state where we can do more and more with less and less. But right now we have to conserve because tissue is the issue. Next one. So very important. There has to be some pre-analytical variables. You've done a biopsy. You fixate that in 10% neutral buffered formalin. That is the most important thing. The fixation time for the biopsy is 6 to 24 hours. So that is why, I asked them, my pathologist, yeah, biopsy, you have done it. Why can't you give me the result tomorrow? Because you require a fixation time, which is 6 to 24 hours for biopsies and 24 to 72 hours for resection specimens. You decalcify highly acidic agents such as HCl and HNO3, they affect the antigenicity and degrades DNA. That is why only bone biopsy is a no-no. Next one. So now this is for me, if there are any residents listening to all these things, I doubt people will be listening to this. Just look at this. If you have a small biopsy, if you have a glandular differentiation and mucin, it is NSCC ADC, that is non-small cell carcinoma, adenocarcinoma. You do not need further IHC. If you see intercellular bridges or keratin pearls, it's a NSCC squamous cell carcinoma. If you don't require IHC for any of these two. If both these criteria are absent, just do a 2-marker IHC. No 4 markers, no 10 markers IHC. Just do a 2-marker IHC. Do a P40, do a TTF1. If TTF1 is positive, it's a NSCC favor adenocarcinoma. If it is negative, it is NSCC favor squamous cell carcinoma. If it is nothing, NOS. Don't waste your time in doing CK7, CK20, this thing. If your radiological picture is okay, don't waste the time because it is rather better to use the tissue for the further biopsy. Next one. So this is how the report actually looks like. Non-small cell carcinoma, adenocarcinoma with solid acinar pattern, numerous signets, that's also evident. Next one. And this is how in today's world, I just got a patient and he said, oh, thank God, doctor, I've just got not the coronavirus. So, in today, we were the only people who said, Mubarak ko aapko tuberculosis hua hai. Now, cancer actually has become second more dreaded C. The COVID has become the most dreaded C right now. Next one. Yeah, so now you have a small biopsy which says ADC or favor ADC or NOS. Next one. You go and test basically for these are the 3 tests. So EGFR, ALK, ROS and BRAF mutations are a definitely must to do test. You can, the second line, you can the 5, 6, 7, 8, you can do MET exon 14 splicing, RET and HER2 new exon insertion. This is the second level of test. This is a must one. The next one, next slide. It's a good test. And maybe the remaining from 9 to 15 could be a part of the NGS panel and we can do it later on. Next one. Yeah, so this is not outside a multigene panel. Next slide. So next one. Next one. Yep. Next slide, please. Okay. So how is EGFR basically tested? Very important. The EGFR test for mutations in exon 18 to 21, and this is how the report looks like. Now you have 4, 5, 6, 7 different tests which can detect this. Sequencing, pyrosequencing, ARMS is the one which actually is the most important test which is used to detect EGFR mutation. NGS can pick up EGFR mutation even in tumor where the tumor DNA content is 1%. Next one. What is not recommended is EGFR by IHC and EGFR by FISH. So if there are 2 tests which are not recommended, they are EGFR by IHC and EGFR by FISH. My friends from AIMS will differ. Kumar will differ. Kumar will now have a slight smile on his face. You can sometimes use the IHC. Next slide, please. You can sometimes have the EGFR. Next one. You can actually have a mutation-specific IHC which has got a high specificity, but the sensitivity is low. So it can definitely miss some of the mutations. Next one. Okay, so these were the updated molecular testing guidelines for selection of lung cancer patients. These are the CAP guidelines. And again, next one. It says basically the laboratories should not use EGFR expression by IHC to select patients for treating EGFR TKIs. Next one. However, liquid biopsy can act. Next one. However, liquid biopsy in some clinical setting where you do not have tissue and liquid biopsy by cfDNA can definitely be used. We have been using ddPCR. In fact, over a period of time, we have been using more and more a non-smoker patient. We do the biopsy. We also send the ddPCR or COBAS, and we actually are getting EGFR mutations now in 2 to 3 days time along with the biopsy report. Please do not use it without a biopsy report. It is not a substitute to a solid biopsy. You can ask for liquid biopsy if you want to expedite your report, but not prior to that. Next one, please. Next one. So mechanism of acquired resistance. This is our T790 testing algorithm. So important, you have given a first generation or second generation TKI. The patient progresses. You test for T790M in the blood. If it comes as positive, you start patient on osimertinib. If it comes as negative, you do a solid tissue biopsy and then test for T790M in that. If it comes positive, treat with osimertinib. If it comes negative, you have to go for chemotherapy or alternative treatment. That's the T790M testing algorithm. In the second line, once the patient progresses on the first or second generation TKIs. Next one, please. So this is just, I mean, we all have seen, this is a patient who was diagnosed to us in 2015. We can just go away. Just go to the next one. Go to the next one and go to that. So this guy is still alive after 5 years. The guy has not yet seen a single chemotherapy. He initially took a second generation TKI and then got osimertinib, had leptomeningeal mets, and has actually improved from there. So to 5 years, not even seeing a single chemotherapy. Now, EGFR is not alone. Next one slide. You have some other sides of the story. ALK. Next one. And ALK, actually, we can detect by multiple methods. We can detect by IHC. We can detect by FISH. But what is very important is this is the LX trial. And what they did was ALK positive by central IHC testing. Next one. There are multiple trials. Next. There are multiple trials, actually. This was the ASCENT 4 study, which again tested it by IHC Ventana test. Next one. This is also next one. Next one once again. So there are multiple trials which are actually using IHC and they are not specifying FISH as a diagnostic test. So next one, you don't require actually need to confirm. You don't require to do both IHC and FISH. ALK IHC by D5F3 is actually very, very important. Next one. So has ALK testing made a difference? Next one. This is the most important graph. Can you just show me the next one, please? So just look at this. If a person actually was ALK positive and got TKI followed by TKI, you had a 5-year survival of around 60 to 70%. However, if you did not get any TKI or only got chemotherapy, the survival was very dismal. And that is the power of testing an ALK positive or doing a biomarker testing. And that is why this is next one, please. And that is why this gap actually shows next one. Actually the impact of biomarker testing, and we should definitely be doing testing for ALK. Next one. So just when you thought it's all getting over, how can I not quote Shah Rukh Khan in any one of my talks? There is still more. It's not only about EGFR and ALK. Next one. So there is something called as ROS testing, and this was an article published in NEGM which was said ROS1, which is targeting the 1% in lung cancer. Next one. And this was our own paper, which basically said that we had a 1.6% incidence positivity of ROS in our center. Next one. And again, we actually have to look over here. Next one, that the ROS has to be tested by FISH. Please remember, ALK positive by IHC does not need confirmation by FISH. ROS1 positivity by IHC needs confirmation by FISH, and we should not actually treat on a ROS positive IHC. Next one. So what about the non-oncogene addicted NSCLC? Is there any hope? Next one. And definitely there is a hope for immunotherapy. Next one, please. Next one. And this is where we got the PDL1 testing. Now, PDL1 also has become a very important biomarker, and it has come into all the guidelines. We should actually do PDL1 testing. Next one, please. And actually, there are multiple methods which are available to test the PDL1. It can be SP142, SP263, 22C3. Next one, please. And there was a blueprint study which basically says that almost everything is similar except for the SP142, the green one, which is an outlier. So as long as you are, there's a good amount of chance that whether you are 22C3 or SP263, you are going to be, results are going to be similar. However, if you're using SP142, then the results are going to be, it's an outlier, and we should take it with a pinch of salt. Next one, please. So has this made a difference? Definitely, PDL1 testing has made a difference. Next one. You actually go and see the amount of survival which is increasing if you actually go ahead and give immunotherapy to a person of PDL1 positive, and definitely it has made an impact. Next one, and that's almost my second. Next one, please. That's almost my slide. And this is also to show that if a person has got a biomarker which you tested, and the patient which comes over here, if you give him the target therapy, the survival is here. And if the patient actually is biomarker positive and you do not give him target therapy, the gap actually is again huge. So definitely we should go ahead and do biomarker testing for all the patients who are selected for that. Next slide. And that's my last slide. People know this is my favorite slide, but I would just like to say, hope was there in breast cancer. Hope has now come to lung cancer. And I hope and pray that hope for us also comes for coronavirus patients, so that we can all meet together, not in a virtual way, but in a face-to-face, and we should be able to beat this COVID virus also. With that, stay safe, stay happy, and looking forward to all the questions. Thank you.
Thank you very much, Ullas. Now we know that you only want to debate with Kumar and Sahu and Senthil. So I'm going to miss that opportunity to have an exciting battle with you. But you did a fantastic job. Now it is over to Dr. Kumar Prabhash. He also needs no introduction. He is a professor and head of medical oncology at the prestigious Tata Memorial Hospital. So Kumar, please go ahead.
Hi, good evening, everyone. And I thank the organizers for this opportunity. And yes, Ullas, we miss you meeting face to face, which is always very enjoyable. But it is also equally enjoyable to see you, and after some time. So my topic for today's presentation has been the top priority for oncologists managing a newly diagnosed metastatic adenocarcinoma lung in COVID era. And what I'll try to do is, part of it has been talked by Ullas. I'll be briefly touching on that, and I'll be focusing on the therapy part. Starting with, okay, so can we go to the next slide, please? So what do we do that you had the test, that patient has adenocarcinoma, and if the person requires a repeat biopsy, and if it requires a repeat biopsy, as Ullas kept emphasizing, your markers are very important. This helps you in managing your patient. And he did mention that almost if you take all those markers together, almost 40%, that is 4 out of 10 of your patients can be managed by tablets. And I'm sure in any era, and definitely in COVID era, most of us will be very comfortable. So, and if the repeat biopsy is needed, maybe CT guided biopsy may be preferable, because bronchoscopy, you have a lot more chances of exposure. So I see a bit of inhibition among people if you put EBUS or bronchoscopy to be done in this time. So that's a bit of a perception. I am sure we can have more discussion, but I don't say it can't be done. If you have all proper gear, sure, it can be done. But CT guided biopsy looks like there you don't have something extra risk to the person who is doing. Next slide. Now, if you do have oligometastatic disease, then what do you do in this setting? If it is required, should the surgery be done? This is by and large acceptable that these are life-threatening situations. And yes, here preferably surgery needs to be done, and it should be the part of the plan, except with the caveat that yes, maybe after systemic therapy, especially in a situation where systemic therapy is needed, unless you are thinking in some of those lung cancer where you have oligometastatic disease and you don't want systemic therapy, then maybe you can go ahead with surgery upfront. But otherwise, it may be good that you give some systemic therapy and go ahead with subsequent definitive treatment, that is surgery in this situation, if you plan to choose it subsequently. Neoadjuvant chemotherapy use, we should be a bit more liberal during this era, the era we are living in, especially when there is a bit of an inhibition from a surgery side to do the surgery during this time. But that gives you those time window period to give the systemic therapy so that disease doesn't progress. And as this COVID era settles down and people become a bit more comfortable, then the surgery can be done. Next slide. And what should be the approach for the same kind of patients if they are elderly and if there is a multiple comorbidities? And the approach should be same? No, not necessarily, because we do understand that the chances of complication is higher, especially in this COVID era. Not I'm saying because of treatment, but in case the patient contacts COVID. And that is the time when we start thinking about that, can we give radiotherapy in this situation as far as the local therapy is concerned. Systemic therapy should be considered, especially if we plan that patient can tolerate it in this situation. And if we plan the systemic therapy is planned, then systemic therapy should be followed by SPRT. Next slide, please. Now, post-surgery, what we do in this oligometastatic setting. If you have a high-risk group of patients where you plan that patient needs a systemic therapy, then they should receive it. A neoadjuvant and adjuvant therapy, it appears in COVID era also. In lung cancer, it appears most of the people think that this should be followed similar as we have been doing in non-COVID era. So maybe maybe what we think that most likely we should have a similar kind of approach as far as the systemic therapy is concerned in adjuvant and neoadjuvant setting in those oligometastatic patients. Go ahead, next slide. Diagnostic test, Ullas talked about it, and he did emphasize multiple times that lung cancer is the poster boy for our precision medicine. We know that it has made a big difference, and I totally agree with him. In this COVID era also, we do require those molecular tests for our patients. Only problem starts that if the first biopsy has failed, then what do we do? And I do counsel my patients for second biopsy. Does in COVID era my approach changes? Maybe, and this is again, I won't say with backed with evidence, but maybe some logic that if you have a liquid biopsy available with you, where you can have all these markers which can be done in liquid biopsy, then maybe one can do it. And if it is positive, then you can avoid the repeat biopsy. But again, if it is negative, you are back to the square one, and it is not easy to say that you won't be doing a repeat biopsy in these patients. Go ahead, next slide. Coming to systemic therapy in advanced stage non-small cell lung cancer patient. As far as the chemotherapy and immunotherapy or chemoimmunotherapy is concerned, Ullas showed some wonderful slide, and that we need to remember that if you add chemoimmunotherapy to these patients, then the survival benefit at 2 years, what you're looking for, the survival difference is around 15%. And in group of patients, it may be as high as around 20%. Once we talk about these kind of survival in these patients, then it is not easy to think that can we defer those therapy or can we avoid those therapy. No, it looks like in this situation, it is important that the planned systemic therapy is considered for these patients when chemoimmunotherapy is given to these patients. Is this a chance that how do we administer? And this is something which slowly looks like it is picking up in our country. There is a lot of evidence that it is being done in abroad, that are you able to administer a systemic therapy at home? That system looks like there are some startups there. And if we go to those startups which are successful, comfortable, then it may pick up as the time goes by. What I wanted to emphasize why I said that chemoimmunotherapy or immunotherapy is important part and should be as we follow. Otherwise, remember the 5-year survival of these patients are around 30%, and that is practically unheard of. And if you don't give this treatment, we do know from the experience that in few months, these patients, the performance status deteriorates and it becomes almost unlikely that you will be able to deliver them. Alone chemotherapy, again, we know there's a good data that survival improves, and especially quality of life and symptom improves. Most of the advanced non-small cell lung cancer, they are symptomatic, and it won't be easy to defer those treatment for these patients. And in these symptomatic patients, if we don't administer treatment now, in all probability, symptoms will be more, and it will be tough to give those treatments subsequently, especially if the patient is fit to receive this chemotherapy or immunotherapy or chemoimmunotherapy. Next slide. Coming to the next group of patients, that is systemic therapy in advanced stage non-small cell lung cancer, that is adenocarcinoma, the targeted therapy. And this is something which we are all excited about, and we heard a lot from Dr. Ullas, and I need to emphasize that here I don't think so. This is one situation we all want our patient to be in. We always wish that our patient has one of those tests positive, where we are able to give them those tablets. So I don't see any reason that in this COVID era, there will be any change in giving this therapy. So if the patient is molecular test positive, if there are tests suggesting that a kind of systemic therapy, that is oral tablets as a targeted therapy required, that needs to be administered to this patient. And in this COVID era or previous era, I don't think so. This makes a difference in administering the treatment. Go ahead with the next slide. Now, coming to the next question for systemic therapy in advanced stage, what should be the schedule of those systemic therapy? Now, this is something we should always look for. Is there any evidence for us to see that can we give those systemic therapy with as much gap as possible? I've given example nivolumab every 4 weeks. We do have some example for pembrolizumab for every 6 weeks. And those things we should always look for in this situation, that if we have a chance of giving those therapy with as much gap as possible, it is always better for patients, that they have a lesser chance of getting exposed to those infection when they are in the hospital or when they have to travel around. So that schedule we should always be looking for. Go ahead, next slide, please. Now, systemic therapy and advanced stage adenocarcinoma, coming to maintenance therapy. And this philosophy remains the same as I talked about it in the previous slide, that if we can have those, that if we can increase the gap. And when I talk to people around the world, in maintenance therapy, they don't exactly stick to the schedule, what is there, what we have seen in that trial. They do change those schedule as per the patient wish as the time goes by in maintenance therapy. So giving it every 4 weeks, scheduling, not being very sure about the schedule of 3 weeks, what we have seen in the randomized trial, and one should consider those. Many times patients do get fatigue, and we all have done those drug holidays. So this is this is one of those situations where one can think about it, that one can have drug holiday with the patient, for the patient, especially after the discussion with the patient. So we do have in maintenance therapy setting where one can consider the schedules being a bit different from what we have been doing in the past, and yes, considering those drug holidays in between, and then starting the treatment subsequently. Next slide, please. What happens to those patients on follow-up? So we know that we have our patients, we know the systemic therapy injectable, we see them every 3 weeks, but the patients who are on tablets, how do we go about those patients as far as the gap in those follow-up and evaluation is concerned? By and large, I do follow them every few months, and that may vary from 2 months to 4 months. And I do know my colleagues, they also, it varies for them depending upon the patients and depending upon their practice. But here is again a situation where I'll always prefer that if my colleagues, I will prefer those schedules where there is a maximum gap. So if I'm following 2 to 4 months, I'll prefer those 4 months rather than 2 months gap in this situation, especially those patients who are asymptomatic and the scan for this has been in the past and where we know that the response has been good. So it is not a bad idea to miss those scans in between, especially those patients if they are asymptomatic. And if you ask me, in fact, this is literally, we are doing this on daily basis at this moment. We are calling our patients, we are talking to them on this, and they're from all over the places. And last time when we had this online discussion with our patients, and it was to our big surprise, we had more than 100 patients wanted to know what to do in a whole different situation. And one of those common situations was oral tablets and how do we come for follow-up. And we kept talking to them. We tried to get a hang of it because they are almost 1,000, 2,000 kilometers away from here, trying to find out if they are asymptomatic, tablets, continue those tablets, trying to arrange the tablets so that it reaches them, and then maybe they have their follow-up subsequently rather than coming right away. So this is something one can do it, and that may not compromise the outcome of the patient in a big way. So these were my thoughts. We do understand whatever I have talked about in this COVID era. This is one of those time when we talk less about evidence-based medicine. This is a part evidence-based, but a lot of those logistics-based, a lot of those logic-based, which not necessarily everyone will be doing in a similar way. But sure, we can keep learning from our colleagues with each other, knowing what others are doing, and we do pick up from them if they are doing something, and this is the way it has worked out for them. That is similar thing we'll be applying in our clinic as far as our patient care is concerned. Thank you. Thank you so much.
Thank you very much, Kumar. That was really fantastic. And I think the last point that you made is exceedingly appropriate. That sometimes in COVID pandemic era, we have to make decisions which are beyond our control based on the limited possibilities that we have. So that is really an important point. And there are several questions that you will have to answer in subsequent time. But right now it is my turn to and privilege to go to the next speaker. May I ask Dr. Sharmila to please make her presentation on how to manage radiotherapy for lung cancer by minimizing travel and exposure during the COVID pandemic. So over to Dr. Sharmila Agarwal, please. She is from Jaslok Hospital, and they had, he recently faced the closure because of the COVID cases. So she has some first-hand experience on this.
Hi, good evening, everyone. Thanks, Dr. Purvish Parikh sir, for giving me an opportunity to speak. To be very frank, I'm still in shock. My world has changed upside down, and we do not know when the end is likely to be to this COVID infection. As of 20th April, all of you know that we are seeing close to 2.3 million cases and almost 1.7 lakh deaths. And WHO says that it's far from over. Worse is yet to come. And that is the reason why I am really worried. I have been asked to speak what changes would we make while giving radiotherapy treatment with respect to the lung cancer patients. Next slide, please. Next slide, please. One slide back. Yeah, next slide. Just like the pandemic, go back one more slide. Thank you. Just like the pandemic, there is a lot of literature which has come or which has been published in last 15-20 days. Most of the literature is coming from the center where the pandemic has started, obviously the China. The Chinese data, which says or talks about a nationwide analysis of cancer patients with SARS-CoV-2 infection, talks about that the highest patients or the large number of patients had lung cancer, and these were the patients who suffered a very aggressive course, had a lot of ICU admissions, and almost 25 to 30% of patients were of lung cancer. Next, please. I'll be talking today about the recommendations which have come from the European and the American Society of Therapeutic Radiation Oncology. These recommendations have come on 1st of April, and they will guide us in the way in which we have to treat the patients during this pandemic. Next slide, please. They talk of two scenarios. One is the scenario in which we are presently, the early pandemic, wherein my resources were sufficient, but somebody in our ward tested positive, who was admitted for a non-COVID or some other kind of surgery, but was not tested at the time of beginning when he was admitted. But then we ended up the BMC ended up in closing up radiotherapy department along with the entire OPD and as well as the inpatients in Jaslok Hospital. What they talk of, or what the American and the European experts are talking about, in the early part of pandemic, you have to stick to the standard of care rather than deviate from standard of care. Postponement or interruption is only recommended in case we get a COVID positive patient, and that COVID positive patient infecting other patients and also infecting the healthcare workers. Also, the risk is much more in this case. And they also talk about one scenario, which is the late or severe pandemic. In the late scenario, they say that your resources might be restricted. Some of our healthcare workers might be quarantined, as it is happening. We have seen for the last 15-20 days. So many cross infections, all are asymptomatic, but they are coming positive because there has been extensive testing which is going on in Jaslok Hospital. All of them have been quarantined. We are losing a lot of healthcare staff because of that. There might be resource restrictions in the terms of that if there is a breakdown of the machine, and if my engineers or service engineers are not able to reach the site because of the lockdown or because whatever is the government rules and regulations, then we may not be able to do. Sometimes there might be some other reasons. So in the later part, they say you have to triage your patients. You have to triage your patients with respect to what is the potential for the cure? Can I wait? What is the risk versus the benefit? If the risk is more, I will wait. What is the life expectancy? What is the performance status of the patient? And if there is an active COVID infection, what will I do? Next slide, please. So I'll be discussing with 6 cases which they have talked about, and these are the cases which we routinely see in our practice. The first case is stage 1, T1, T2 non-small cell lung cancer, which is peripherally placed, which has a PFT which is deranged, has medical comorbidities, and is otherwise not for surgery. Or if the patient is also for surgery, surgery during this period, surgeon may not like to do. So in those cases, our standard of care is SBRT or stereotactic body radiotherapy. So then the experts talk whether would you do any changes to what SBRT plans are approved. We may not do any changes because there was no consensus from their side also. They said ki maybe in 47% of the cases there was no change. In 54% they said ki there might be some change. But the factors which are going to decide whether we give immediate treatment or we wait for signs get a stage, please go back. The T stage, performance status, and the status of pandemic. Are you able to hear?
Yes, ma'am. Please go ahead.
Yeah. So ideally, I would not do any change in case of stage 1 non-small cell in my setup also, because anyway, we are giving only 3 to 4 fractions. But in case I don't want to call a patient even for those 3 to 4 fractions, I might give a single fractionation if it is possible, 30 to 34 gray single fraction. Next slide, please. We are talking about the most commonly seen stage 3 non-small cell, locally advanced 3A bulky nodes, which can be encompassed in a conformal radiotherapy port. What was the standard of treatment in these cases is chemoradiation. We usually would have given 60 to 66 gray in 30 to 30 fractions. In this pandemic period, I may not like the patient to come for so many times and risk himself to the COVID-2 infection. But the experts felt there should not be, first of all, postponement of treatment because it's a very aggressive, the doubling time is fast. So don't wait for pandemic to be over to start the treatment. But there was no consensus whether I would like to change the fractionation. In India, we might change from 30 fractions to maybe 55 gray in 22 fractions, but we cannot reduce further because of the toxicity. Next slide, please. In same patient, if my medical oncologist is not able to give concomitant radiochemotherapy, will I change the fractionation if I'm going to give only radiation, or if we have already given chemotherapy and then we are taking the patient for sequential radiochemotherapy? In these two indications, wherein only radiation or sequential radiochemotherapy can be given, we might change to hypofractionation. But with concomitant radiochemotherapy, it is better that we avoid hypofractionation because we'll be increasing the toxicity. Next slide, please. Okay, coming to case 3. This is a case which has been operated by our surgeon, and there are residual nodes. Multi-station nodes are positive, N2 disease with ENE. Patient has undergone surgery. Standard of treatment in this cases is to add radiotherapy to 50 gray and 25 fractions. With respect to COVID pandemic, what will I do? I might postpone the treatment. And there was a consensus from both European and American experts that we can postpone this treatment till the pandemic subsides or till we get some breather. Next slide, please. Coming to limited stage small cell lung cancer. Limited stage small cell lung cancer, it's a very high priority treatment. Treatment is with chemorad. We usually give 60 gray and 30 fractions. The experts felt that first of all, you cannot postpone this treatment. It is important that we give the treatment. And there is also consensus that we cannot change the fractionation. Next slide, please. Coming to limited stage small cell lung cancer, post good response to chemotherapy, would I consider these patients for prophylactic cranial radiation, or would I consider them for thoracic radiotherapy after completion of chemotherapy? Ideally, we do 25 gray and 10 fractions to the whole brain. But all the experts, both American and European, agreed that we should postpone the treatment in these cases. Some of them felt that we can do MRI brain with contrast enhancement, but even to come for MRI brain in this phase of pandemic might be difficult for the patients. So ideally, I would like to postpone unless the things are under control, and may follow up with MRI if MRI is possible. Next slide, please. Okay, coming to palliative non-small cell lung cancers. These are the patients who have received chemotherapy, who have progressed, or who have come up with mediastinal disease, which is causing pressure, who have come up with cough, who have come up with breathlessness, and they need to be treated. I would have otherwise, without this pandemic, treated them with 30 gray and 10 fractions. It is a palliative situation. We need to give them relief. So experts felt, and I also agree, that we should not postpone their treatments. Only thing is we might come down from 10 fractions to maybe single fraction or 2 fractions a week apart, or maybe complete the treatment in 5 fractions. Next slide, please. Okay, at the start, we come to know that this patient has COVID-19 positive, and the report is positive, and we are just at the start of the beginning of the treatment of radiotherapy. Most of the experts have agreed that we should postpone the treatment, give adequate time for results to be negative, and then only continue the treatment. And even in case during the treatment, if we come to know that one of the patients has become COVID-19 positive, ideally we should stop immediately. We don't have so many linear accelerators that we can give a dedicated linac for these patients. So we will give a break, wait for treatment of COVID-19 infection to be completed, wait for 2 consecutive negative reports, and then only start the treatment. So next slide, please. I think that's the last slide. To take home message is adequate precaution to all patient, staff, as well as the machinery. We have to avoid aerosol production wherever it is possible. Minimize the travel by reducing the number of fractions if it is feasible. minimize the stay in the waiting area, communicate with transparency with all the patients to bring out the best so that they can understand where we are and what situation we are. The future for me looks like a single fraction of very dose radiotherapy, what we say, which is still in the experimental phase or just beginning phase, is the flash radiotherapy. Thank you, everyone.
Thank you very much, Sharmila. And I think you have really summarized how to deal with the patient. I was quite impressed with the consensus in the majority of radiation oncologists that for all stages of non-small cell and small cell lung cancer, if the treatment was not started, then they wanted to postpone till such time as the patient is much better. That's really nice. Now we move on to the Shyam Agarwal. He is going to handle the big debate and discussions, and he has a galaxy of panelists with whom he is going to be, boxing around. So Shyam, over to you,
Great.
please.
Yeah, thank you, Purvish. Wonderful lectures. Need to understand how to modify the treatment. Dr. Kumar, Prabhash, Dr. Sharmila, and Dr. Ullas have given us some insights, but I think there are going to be questions, and I think already there are questions from some of the people who have joined the webcast. So we have Dr. Govind Babu, Dr. T. Raja, Dr. Rajesh Mistry, Dr. Randeep Singh, Dr. Anurag Mehta, and Dr. Pooja Patel from Ahmedabad. I think she's a radiotherapist. Right. So I think let's begin. I think initially the thoughts were on the molecular testing. There are a few questions. I think I'll just start with those from Dr. Amit, and which is pertaining to IHC positive ROS, and the fish is not possible. So Dr. Anurag, what do you think? How do you should proceed with this patient?
If you have a tissue, you should
So the
send it
tissue is not there anymore. It is IHC ROS positive.
and you have no tissue left with you.
No, there is no tissue. I think we've exhausted in the fish and the IHC and all.
So I think you shall go for an liquid-based NGS, a panel which includes fusion rearrangements. For example, there is an oncoma in DX lung cancer version 2, which includes 4 fusion, and that can take care of the ROS1 fusion rearrangement as well. So
Okay.
I think the option will be to go for the liquid biopsy.
Perfect. So the other question was if the ALK is fish positive and IHC negative. So it's straightforward, I think.
So I think you have to go ahead and treat, because there can be discordance on either side by 2 to 3%. And but these discordance are known, and the response is expected. So I think the treatment shall be administered to this individual.
So the final question was, I think Dr. Ullas made a comment regarding the selection of the primary site versus the secondaries. So what do you think is the discordance between the two tissues?
So these lung cancer mutations, these are truncal mutations. They will always exist in the primary as well as in the metastatic sites. In the metastatic sites, what can happen? There may be some additional mutations which can come up. But if you are primarily looking for the tier 1 mutations, whether you check in the metastatic sites or you check in the primary sites, the discordance is very, very minimal, to the range of about 1 to 2%. And therefore, you can use anyone, either the metastatic or the primary site tissue, for making your diagnosis of the predictive biomarker.
Right. Thank you. Thank you, Dr. Anurag. I think let's move on to a couple of slides which I have. So which I could pick up from the literature, because it is too early to publish, I guess. But this is a patient who was treated again from, I think, Guangzhou, where the patient was EGFR positive, and patient was given osimertinib, even while the patient became COVID-19 positive. And I think the slides here show that there was a patient who had fever, and you can see the CT scans where the lesions were there, and the viral pneumonitis was reported on the CT scans. So can I bring in Dr. T. Raja, because Dr. Kumar Prabhash did touch on the subject of continuation of the TKIs while somebody gets COVID-19. So Dr. T. Raja, your thoughts before we get maybe Dr. Kumar Prabhash. Dr. T. Raja is there?
Yes, I am there. Thank you, sir. Thanks for the question.
Yeah, please, sir, please.
At this point, the current data says that most of the TKIs are quite safe to continue, even in patients who have positive COVID-19 infection, and there is no contraindications to continue the TKIs. Unlike some debate about immunotherapy and interactions with the pathways that immunotherapy causes, immune-related adverse events versus the COVID-19 causing the pathophysiology of COVID-19 causing lung injury. They seem to have a very identical pathway. They seem to share very similar, lymphocytes pedigree to. So that is a debate that's going on. Just to illustrate the point is the TKIs are currently considered to be safe to continue. The only challenge from what you point out is if a patient is on treatment. For example, we recently had another patient who was on radiotherapy. Madam Sharmila was showing, and the patient was half the way through, and then we saw some patchy numeric changes, and the patient has slight symptoms, and we panicked whether these radiological changes can be a surrogate marker for COVID-19 infection. So that will be a new challenge when we follow these patients radiologically. Otherwise, if the patient has no new symptoms, no new respiratory difficulty, other than what he or she presented, I have no issues in continuing the currently available TKIs, particularly if the patient is responding.
Yeah, so I think Dr. Sharmila did make that point that if somebody, while getting radiation, gets the COVID positivity, so the therapy needs to be interrupted. So, Dr.
No, I'm not talking about the COVID positivity, but
Yeah.
here is another hypothetical. I mean, it's a real challenge that
Right.
we face. Patients showed changes, and we do not know whether this patient should be tested. That was last week when we were
Right.
not sure which patient to send, how do we send. But now we would probably send the test for those patients.
So since we are on the subject of radiation and the lung shadows, so Dr. Pooja, what are your thoughts on how to approach such an individual who possibly has new maybe radiological changes or some cough while getting radiation? So would you order COVID testing or would you wait for fever to develop? So Dr. Pooja or Dr. Sharmila, can they answer this particular issue subject?
So I'll answer this.
Yeah, Dr. Sharmila, you are there. Yeah.
I'm here. So I guess if the patient is symptomatic and if we think that, yes, this is a new symptom as not seen previously, then definitely we should ask for the COVID testing. Otherwise, if the symptoms are from day one, then probably would not ask for a COVID testing in between. Because there is no point in doing it that if there is no change in the symptoms from the day one.
So Dr. Pooja, before enrolling a patient for radiation, are you advising for a baseline COVID test for all your cases?
So as of now, we are not doing that until there is some strong positivity, in the sense that if the patient is coming from a hotspot area, like we have, you might have been seeing the data. There are few cases, there are more number of cases coming from specific areas, that cases or who have some symptoms or who have a history detail, then only we are asking for a COVID testing. But in all patients, we are not asking from day one for the COVID testing.
Dr. Sharmila, your thoughts? Can we go to Dr. Sharmila? Yeah, Dr. Sharmila, please.
Sir, because we started with a very stormy course in
Right.
Jasloke, presently we are asking COVID testing before we are restarting our department for every patient who is on radiotherapy. Only issue which I feel is going to be very complicated is how frequently will I keep asking this test?
Absolutely. So that's a very, very difficult question, because the patient has to come regularly for. So, what we have done in.
Maybe weekly.
Yeah. So can I?
Is more.
So
Yeah.
what Gangaram Hospital has thought about and possibly wanting to implement is, so looking at the incubation period of the virus. So we decided, or we are in the process of deciding, that patients who are getting maybe weekly chemotherapy should be tested once in 14 days.
Yeah.
So
We
you
are
know,
also coming down to maybe once in 14 days.
Yeah.
That is what we are also
Right.
likely to.
So I think, so the issue is, as Dr. Sharmila said, that since they have a hotspot area and there are a lot of people who are possibly infected, so there they would like to do testing in all, but in remote areas where perhaps the virus has not reached that much, well, there maybe one can be a little relaxed, before starting testing each and every person before enrolling radiation. So I think that's a fair, conclusion on this issue. Right. So I think we can move on to the next slide, Dr. Purvish. So this is for Dr. Anurag Mehta. So, we got this particular article of pulmonary pathology of early phase 2019, pneumonia in 2 patients with lung cancer. So any thoughts, Dr. Anurag Mehta? Have you come across any surgical patient where there was for Dr. Anurag, please? So what about the pathological changes there? You see the ground glass appearance in both the lungs in a patient who was operated for lung cancer. So Dr. Anurag, are you there? Can you comment on this?
Yeah. I heard you partly.
Yeah.
What I think, these changes are the changes of acute respiratory distress syndrome. The changes are characterized by desquamation, hyaline membrane formation, and there is a proteinaceous fluid which collects, as you can see in these images. So the changes are pretty non-specific. What you see in any acute respiratory distress syndrome, the same kind of changes are seen. They usually involve both sides of the lung. And what else do you want to know from me? In this situation, I personally no experience of having seen a COVID-19 specific.
So I think this brings us to the
features of ARDS are shown here.
Right. Thank you, Dr. Anurag Mehta. I think we can move on to the next part.
Are shown here in these images very, very distinctly. Desquamation, filling up with the proteinaceous fluid, and a hyaline membrane formation.
Sure. Yeah. Thank you, Dr. Anurag. I think we can move on to the surgical part now. Dr. Rajesh Mistry is with us. So the question is, I think you've all gone through that particular article where the issue of incubation period is there. So Dr. Rajesh Mistry, so what do you think about, I think Dr. Kumar Prabhash did mention about delaying surgery. So how are the surgical oncologists looking at patients with lung cancer, especially in the early stage? Dr. Sharmila is there, Dr. Pooja is there. They want to, jump onto these patients for radiation. So what are your thoughts? What are the surgical people thinking and doing?
Yeah, so thank you, Shyam. There is no change in policy as far as indication for surgery is concerned. So if a patient has stage 1 or, select stage 2 cancers, they would be considered for surgery. However, it's a policy now at most places and particularly in our hospital to test all patients for COVID-19 along with the HCV, Australia antigen and HIV. And this test is done within 24 hours of planned surgery. If the patient is negative, then we go ahead with surgery. If the patient is positive, then of course you don't go in for surgery and then have to wait for either him to become negative or offer non-surgical treatment.
Right. So the thought process regarding, a tumor which is less than 2 centimeter, does it, do you want to hand it over to the radiation oncologist, or you would like to wait for a couple of weeks or 3 weeks until this, lockdown, etc. is over? Yeah.
No, if the patient has reached the hospital, if the patient is medically fit to undergo surgery and patient is willing, then we would offer surgery provided, COVID test is negative. So we routinely do all patients, any admission, in fact, in our hospital has to go through a COVID testing, and then only patient is taken up for admission. So for surgery, the same thing holds.
Right. So I think, as you are aware, that the false negativity rate is around 30%. So I think there was a question from one of the people who was in the webcast. So what tests are you doing, or what tests would you like to do before you have everything available? So then would you like to just do RT-PCR, or you do like more testing?
So we are right now doing only PCR, but the recommendation is to do both PCR and antibodies. If the PCR is positive and antibody is negative, you go ahead with surgery and then keep repeating the PCR once every 7 days. If the both the things are positive, that is the antibody is also positive, then you don't have to repeat the PCR again and again. So you will go ahead with surgery, and of course, whether the patient is positive or negative, you will take all the universal precautions like you would take for a patient who is, seropositive.
So Dr. Raja, so Dr. Mistry says if the patient is RT-PCR positive, so is that justified to go ahead with the surgery?
No, I'm saying if the
No.
patient is...
I think the surgical guidelines have now come with 3. I think that's what Rajesh sir is referring. I believe, I think it was just released last week. 3 possible scenario where the PCR is positive and antibody is negative, and the PCR is negative and antibody is positive, and both being positive. So I believe that's what he was alluding to. It's very clear that if your PCR is negative and your antibody is positive, you have faced it, you have overcome it, you are safe, and you don't need anything else, you are good to go. But if you have a RT-PCR positive, and then whether you have the antibody positive or not, you have to wait for the infection to go away. Just adding to what sir said, it's very interesting that he said that all patients, after getting a hit in those hospitals, they are now, contemplating that all patients who are getting admitted would need a test. And we also heard, Madam Sharmila say that all patients for their radiotherapy, when they want to restart, they need a RT-PCR done and then repeat it every 2 weeks. My dilemma, which all our surgeons today, we had an advisory committee meeting, they all asked me that, look, you are handling your lymphomas and aggressive lymphoma protocols and all. Shouldn't you be testing your patients before admission, at least all our chemotherapy patients? And my dilemma is we don't have a guideline, we don't have a backup, we don't know whether to recommend or not routinely for all our chemotherapy.
Yeah. So can we move on to the next slide, please? Yeah. So Dr. Mistry, again, the question is to you. So is the surgery for lung cancer still elective, or you have some, guidelines?
No, it is an elective surgery. Like I said, if the patient is fit, medically fit, and if he is COVID negative, we will proceed with surgery. But there is no great hurry. There's no great hurry.
Right. So Dr. Ullas,
surgery, yes.
Ullas, you're on the screen. So what are your thoughts on, postponing surgery by 2, 3, 4 weeks in a patient who has a tumor, say less than 2 centimeters, and the patient is largely asymptomatic, So there was a question from the audience as well.
Sir, just in case the patient, because there was a paper from China which said that people who have undergone surgery and they had a very high mortality rate
in the incubation period.
Yeah. So I would rather wait for 2 weeks, 4 weeks, and then do. That's my
for a small tumor.
For a small tumor not causing symptoms, heavens are not going to fall. Yeah. Although the surgeons will differ.
Yeah, if the patient is medically fit, COVID is negative, and you take all the universal precautions, including the anesthetist who will use an aerosol box for intubation, reducing the number of people who are in the theater. So, and you keep repeating the COVID every 7 days if the patient is going to be in the hospital for more than 7 days.
So it's not a question of COVID being repeating COVID. The point is, if it turns out to be positive, the mortality rate is very high. So probably for a 2 centimeter less tumor, we probably, to my mind, a medical oncologist's mind, the risk is more, the benefit is less. But that's always the way medical oncologists think about surgery.
Yeah, that's right. But so, you can differ, like you said, 70% of the times, or maybe 80% of the times you will be right, Yeah. And there is no harm in waiting. If somebody wants to wait for 15 days, 1 month, I don't think I will, have a I'll completely agree with that also.
Dr. Kumar, you want to comment on the surgical part?
With Dr. Mistry that not every surgery has been deferred. Lung surgery has been continued at TMH, esophageal surgery was deferred and it has again started. So doing a test. At this moment, we are not doing all patients going for surgery for the test. But that is one discussion which has been going on for some time in our hospital, that should be doing for all of them the way it has been done at Kokilabhen.
Okay, Dr. Raja, you wanted to say something on this?
Last week, the ESMO guidelines had been published for all the scenarios, particularly ESMO guidelines for lung cancer.
Yeah.
In which they have defined that all T1 disease, when to wait and when not to wait, and that's one of the questions that I did post for Ullas also. If you look at they have defined that if the size of the tumor is let's say less than 5 centimeters, and if it's a classical stage 1 disease, you can even postpone your investigation. You don't even have to investigate them when you are very clear that the expected longevity and all. So there are clear scenario description, multiple descriptions have been given, multiple scenarios have been alluded to: high priority, medium priority, and low priority for
Right.
non-small cell, for even for small cell.
Correct.
Surgery and radiation and chemotherapy options have been all enumerated. I think for small tumors, there is a guideline recommendation
Correct.
that you don't even have to investigate.
Right. So Dr. Mistry will have the last word on the surgical part, and then we move on. Yeah. Dr. Mistry. Yeah.
Yeah, no, so the point that I had wanted to make was that, in Western countries, they are deferring surgery partly also because they don't want to burden the ICU. But in a place where there is no pressure on the ICU, we have adequate beds, the ORs are available, then staff is also adequate. That's the reason why we are not waiting for, 15 days or 20 days unless there is some strong suspicion, travel history, something like that, If it is a straightforward case, patient is fit, there is no pressure on beds. We don't have to keep, beds reserved for possible outbreak and, things like that. So that is the reason why we are going ahead with surgery.
Yeah, I think that's a very, very valid point, because in Europe and in USA, I mean, we just tend to follow them blindly. You look at the number of cases which are detected positive as opposed to what we are seeing in our scenario. So we should be careful. We should do all the tests, but perhaps should not be as scared as I think the Americans and the Europeans are. So just because of the difference in the numbers of patients being detected. Yep.
Sorry to interrupt you. I believe Dr. Govind Babu has raised his hand.
Yeah, sure. Yeah, please bring him on.
Sir.
I can't see him. So we are going. Dr. Govind Babu, please make a comment, please. Yeah.
My question was, if a surgeon is not willing to do the surgery, should we use this as a to look at chemotherapy or immunotherapy for operable cancers?
Ullas or Dr. Kumar, Prabhash, anybody can take this. There is some data for neoadjuvant immunotherapy and chemotherapy, but if it is a small tumor, one can think of even SBRT,
yeah, of course.
Yeah,
of course. I'm just looking at it as a window of opportunity for us if we can try something like that.
So I don't know whether they're looking at a window of opportunity, but then, I mean, if there's a real constraint on the ICU or on the issue of COVID, well, certainly one can, but I think Dr. Mistry is saying that he is not hesitating in doing the surgery.
That's right.
Yeah. So can we move on to the next question, please? Can we move on? Yeah. The next, I think we've discussed this, the surgery part. Next. So I think now the question is on the adjuvant chemotherapy. I think this was partly Dr. Govind. If a patient has undergone surgery, so what is, I mean, and the patient has a tumor which is, say, 5 centimeters and 1 node positive. So would you, I mean, I think this is a candidate for adjuvant chemo. So would you do it right away, or would you wait, or what is the thought process there?
I think I'll definitely go ahead and give, because he's undergone surgery. That means that we have shown that he's, even if you have not tested, he's gone through the incubation period. He's not symptomatic now. So
yeah,
I would
so he's gone through
go
the
ahead,
surgery.
but before starting the adjuvant chemo, probably I will do a test for the COVID.
So Dr. Kumar Prabhash, because this is a curative setting, so
Yeah,
what is your
absolutely.
thought? Yeah. Dr. Kumar?
Yeah. If there is a node positive case, then it is better to give. For example, if we have something of around 4.5 centimeter lesion and node negative, then the benefit and the risk will be different from the patient having node positive patient N1 or N2. Then it is better that we give it now. But at the back of the mind, we also need to remember that by and large, those we do have those around 3 months cutoff where we have the time that we can administer it later. But node positive, I'll prefer if there is no other issues in delivering the therapy.
So I think very valid point. A patient who has a high tumor burden with node positivity, and even for that matter, extranodal extension. So those would be high risk candidates who would benefit more from adjuvant chemotherapy, and therefore one should do it. So Dr. Raja, please. Yeah.
If we just have to fall back on the guidelines that are available, nothing
Correct.
is foolproof, as you rightly said. Europe is not India. It is guidelined that the T1 and T2 up to T2B, it's considered as low priority. N0, don't treat them. And anything from T2B to T3 and N1, it's a medium priority. And T3 to T4 or N2, it's known as high priority, particularly if the patient is less than 65 years, should receive the normal adjuvant chemotherapy. That's the guideline.
Perfect. So can we move on to the next slide, please? Next slide. I think Dr. Randeep is with us on the panel. We've discussed the radiation part. Can we move on to the next? Next. So, right. So this is, I think, Dr. Govind or Dr. Randeep can take it. So a patient is undergoing chemotherapy and immunotherapy for metastatic disease. So what should he or she do? Stop it or delay it, or what should be the approach in a patient like this? He's undergone 3 cycles of chemo and has kind of stable disease. So what should be the approach there?
Sir, it depends upon 2 major factors. One is that how is the patient? I mean, what is the age, comorbidities, performance status? If it is a fit patient with no cardiac, kidney or lung disease, and he's coming and going, I will continue the chemotherapy and as well as immunotherapy. Of course, my worry is with immunotherapy about pneumonitis, and very difficult to differentiate pneumonitis from corona or COVID. And the main reason is because even if the COVID is negative and someone is showing a pneumonitis like picture, it will be actually, as Dr. Raja also pointed out, it will be actually very difficult for anyone to differentiate. That is the worry. Otherwise, I think it is absolutely safe to continue. On the contrary, if someone is on a 2nd line or 3rd line palliative therapy, or is on someone maintenance pemetrexate and is elderly and has performance status problems, tolerating chemotherapy poorly, so I may avoid. And I think one of the things to follow this is a UK NHS criteria where they prioritize the patients. Even in the palliative, they have given 6 levels priority. Same as ESMO is also doing. And something which is, we call it as personalized therapy. I think this is a personalized therapy in COVID era, where we know the standards, but then we apply. And the one major point, I think we all have to keep it in mind, that in what stage of pandemic we are. And if we are in an early stage of pandemic, we can still take the advantage, because we don't know what happens then after 2 weeks. So all this discussion may change after 2 weeks if the situation deteriorates or if it improves. So that is my way. I would like to continue majorly in patients if they are fit, tolerating well, and on a 1st line palliative therapy.
Great. I think very, very valid points. What stage of pandemic you are? It's a very important issue. Dr. Govind, your comments on,
What Randeep has said is perfectly right. So I think we should go by those guidelines. You weigh between the risk and benefit of continuing therapy versus the problem that he would have because he's at a higher risk for developing COVID. So I think that's how I would weigh about continuing or discontinuing therapy.
Yeah. I think there was a question regarding the interaction of chemotherapy with COVID. So is there any data? Is there any thought process there? The cytokine storm with COVID is known to happen. Does your immunotherapy, worsens that if somebody gets COVID while on immunotherapy? So Dr. Raja is raising his finger, please.
Sir, only one point I wanted to add to what Dr. Randeep already said. Totally agree with not stopping any treatment which is appropriate. Continue. There is no worry. You need to continue. But most of the guidelines, including the ESMO and the NHS1, they have advised liberal use of growth factors. That is one point I just wanted to add. So that's one thing. Second thing is, with regard to your question about the interaction, chemotherapy as such is not shown to have any interaction with the, if inadvertent COVID infection happens, there is no impact unless they are profoundly immunosuppressed. Again, the data is missing. The one very interesting interaction that's happening is with regard to immunotherapy. As we all know, the immune therapy related reactions seem to be mediated through, I have already mentioned, whether they are competing with the lung injury mechanisms of the COVID is the issue. That's the debate, whether immunotherapy can be safely continued or what should we do. That is the pathophysiological crux of that discussion. But the current guidelines, which appeared last week, has advised us to continue immunotherapy also. One publication that came yesterday, just for interest, is that the ibrutinib, the BTK inhibitors, seem to be having a positive effect on the outcome. They seem to be, slowing down the impact of COVID virus. It does something where it gets attached. So BTK inhibitors, particularly ibrutinib, seems to have a positive outcome for the patient.
Dr. Kumar, your thoughts? Because this is an important issue. Dr. Kumar, please.
I think so, sir. One can continue, the therapy, especially the kind of benefits they have with all the usual precautions. So, as Dr. Raja was mentioning, that is better to continue in this setting. Only that therapy duration, if you can have more gaps, have a once in 4 weeks treatment, those modifications can needs to be done. In fact, that will be useful, which ensures that patient is able to take treatment. But in all probability, if the patient is fit enough, those treatments will continue.
I believe.
So I think.
Sorry, sir.
Yeah.
Please go ahead, sir.
Yeah, I think we're all coming to this consensus that if the patient is doing well and is young, is tolerating, so there's no reason to discontinue. But the question is, if somebody tests COVID positive, so should that patient be continued on chemo, number one, number two, immuno? So while the patient is tested positive, Randeep.
Sir, fortunately, I first wish that no one faces that situation.
No, I know, but
think I would like to hold.
I mean, we have to be prepared. That's the whole thought. Yeah.
The answer is that I would like to hold, because we don't know what happens after 10 to 14 days. I mean, he's asymptomatic or even symptomatic. We don't know the scenario. I mean, this is a new disease. And we all know that the world, as well as no one is confident that what will happen to this patient, whether they will mount different responses. Also, we know that the chances, and that is by the same Chinese paper in the Lancet, that if the patient suffers with chemotherapy, the chances of invasive ventilation, ICU admissions are double fold as compared to the normal. So if someone has a COVID positive, I would like to hold. Anyhow, we have a COVID positive, and then we follow the same protocol that we hold the therapy, put him on isolation, repeat it. And once there are 2 negative reports, then we think of restarting. And especially we have more of palliative settings, so we can take an attempt to hold the therapy, and we shall hold.
Yeah, Dr. Govind is there on the, or Dr. Kumar. So if somebody is positive, because palliative chemotherapy will continue for 6 cycles or whatever, and so if somebody tests positive in between, so you should discontinue.
I agree with you, sir. It is good to discontinue, especially in between, because we know that those 2 or 3 weeks we can take out from our schedule for the treating the patient, which we can go back again once the patient recovers. So it will be a good idea to discontinue. Because another aspect is, if the patient develops the complication of this therapy and the COVID, either of them, then we are in a big soup in this situation. But deferring those 1 cycle, which we do many times otherwise also in non-COVID era for many of those patients when they demand, or sometimes because of fatigue. I have patients because of fatigue, I had to defer those treatments. So we know that this can be done.
So can we move on? I think we've addressed this. Can we move on to the next? So, yeah. So what about patients who are coming from outside? your town, coming from nearby areas, maybe 100 kilometers. So how have you been managing? Dr. Adeep?
Hi, sir. So there are 3-4 patients who are actually far off. They can't even come by the road. And I have tried to give them the protocol and try to follow. Of course, if they have an oncologist and you are lucky enough, any oncologist, we have told them to continue the infusion. Otherwise, we have tried to issue them a protocol. And we have been doing this for many of our international patients also, that we give them the protocol and they do follow it. And it's a detailed protocol, which we give it exactly the order to the chemotherapy staff. And that is an alternative as a last, if they cannot travel, because if you have to stop the therapy versus it is better than at least you continue something.
I think Dr. Kumar would have more experience with such situations. Yeah.
I agree. I do have some, sir. And what we have tried is, we have anyway maintained a good list of people where they are around, because we require the help of people all around. And we do try to put those patients to those local doctor in their place. Many times we have talked to them and try to see that if can have infusion. Tablets has not been a problem. Only it gets over how to get those tablets has been a problem. But for infusion, I do have patients who are from real far away places, and there is no one to deliver those therapy. And really, we don't know what to answer them. And they do ask me this question, Doctor Sahab, treatment nahi liya to bimari badegi to nahi? And then also they added that I can't go to the next city. And then we don't have the answer.
Yeah, I think Dr. Harita is asking, does the panel advise COVID testing for all patients prior to going ahead with chemo? I think, so is that the policy at Apollo, Doctor, now, with the test becoming available?
I myself asked the same question just a while ago. And, we saw the chat answers that said that in Bombay, the BMC would recommend that all patients who are getting admitted for chemotherapy needs to be tested for COVID-19. And then there was a clarification in the subsequent, comments that is not, there are some discrepancies there. But I would wish that there is a policy that all patients who are getting active chemotherapy should be COVID tested at least once in 2 weeks, like you pointed out. I would really, really love that scenario, so that for many reasons it will be comfortable. And to add to what both Randeep and Kumar said, whenever we face patients who are far away, what we have done is we have always actively tried to locate somebody close by and try to locate, try to allocate them to the nearest best physician possible. And then if that's not possible, we have sent letters to which there has always been a response from the authorities. They have allowed, they have been issued special permissions to travel between districts and even between states. They have come all the way to us, and then we advise them to stay close to our center if they travel and make it. So that's how we have managed the logistic issue. But testing everyone, I really believe that that's going to be the, but so maybe a quick test, maybe whether that's going to be reliable, specificity, sensitivity. I have no answer to all those, but I would believe that testing everyone before chemotherapy is probably a good idea.
Dr. Randeep wants to say something. Please
there
do.
Has been,
Dr. Randeep.
Discussion a day prior that same our COVID committee wants me to do it every week. So what they have suggested is, since we get patients from hotspot, all patients who are admitted in the IPD for supportive care, they want a COVID. For the daycare, they are saying either you do a COVID every week, or you tell your sister to use PP and consider every patient as COVID positive, because your patients and dialysis patient will not manifest symptoms. And this is one of the policy which Narayana Hridralaya has, many hospitals they are allowing. So that is one of the steps, that we are getting PP for our sisters. And what we are doing, we are telling the patients to come at a particular time, alternate day. And only the patients who are only the sisters who are going inside the daycare, they are wearing PP. Everyone is not wearing a PP. And some added cost is being added to the patients for the PP. I don't know whether this is right or not.
Right. So I think there are several questions which are evolving, and as we are the thing is unfolding. So there's a question here, can we have some kind of ISMPO or guidelines on the COVID testing before chemotherapy, during chemotherapy, etc.? So Dr. Kumar?
I agree with you, sir, that we should have some guideline, and I think so we should be putting in the executive committee because that helps us in multiple ways. There is some standardization, there's something to fall back upon, and there is also allows to discuss with the administration. As the more kits, I do agree today the kits availability is an issue, but as the time goes by, when the kits will be available, that can also become a way to have a discussion with the administration when it should be done. Because I do understand we all want to be comfortable when we want to see our patient, because we see them again and again. They're going in daycare, and one patient in daycare may have an impact on dozens of patients there if they are positive, because they stay in many times for 6 hours, 8 hours there. And if they are carriers spreading, I do get worried, but at this moment we are not doing for all patients.
There's a feedback from Dr. Mudassir, who's at Fortis Noida. He says they have detected 3 asymptomatic patients out of around 30 to 40 tests. So, these asymptomatic carriers are a huge issue with this virus, so which is responsible for, Dr. Govind is still there with us, who can shed some light on the ISMPO guidelines. I mean, if he's still with
Dr. Govind had to leave detail.
Okay. So Dr. Randeep wants to ask everyone, how can we best incorporate antibody testing in onco daycare along with RT-PCR? So this was partly addressed, I think, Dr. Raja. So I think, can we go a little elaborate on this? So there are 3 scenarios, as you said: RT-PCR negative and antibody positive, negative. So both negative. So that means the patient has never been exposed and we are safe. Dr. Raja, please.
Oh, I should.
Surgical. That was for the surgical.
No, even for the chemotherapy.
I'll come to that.
Yeah.
If somebody is RT-PCR positive and they
No,
are.
let's go one by one. So both are negative.
Both
Can
are,
we have Dr. Raja, please? Yeah.
The patient has never been exposed to the disease and has not. To that.
So we are safe in treating him.
We are safe in treating, and then you probably can repeat the test after 2 weeks, like we all thought, incubation period.
And the patient is RT-PCR negative and antibody positive.
Absolutely, it's beautiful situation. The patient has been exposed.
Okay.
Developed an ideal antibody response. Good to go. He is probably also a candidate for convalescent plasma, etc.
Perfect. And if the patient is both positive, RT-PCR positive and antibody positive,
so he is still deemed to be having continued virus harboring. He still continues to be an infective host, and he has also not completed his natural course of the illness. So at this point in time, as everybody pointed out, there is data both from China and also from Italy that the rate of adverse events in such patients and invasive ventilation, ICU admissions are all profoundly high. So these patients should be probably, we can't do anything. And again, as madam, the radiation madam pointed out, even if I have to radiate a patient, or if you need to really produce a very ideal situation wherein you have to exhaust a lot of PPEs and you have to create an ideal room, what to treat them. I think it is not logistically possible. That patient we have to stay away for some time.
Right. So my understanding is that if you have both the tests available, so you will be able to decide with confidence in 99% of the cases. Dr. Randeep, what do you think?
I agree with Raja sir. Only point is that if you have a RT-PCR negative, antibody positive, would you like to just defer the therapy because still he has been exposed and we don't know in which phase of his disease in the natural history of COVID he is. Otherwise, I think there are no guidelines from the Medical Oncology Society worldwide to follow this algorithm. But as the papers are coming from Surgical Society, this is the nice thing to adopt to the medical oncology practice. I think also there was a comment from Ullas. We can unmute him and take a comment from him. And I think once we have some kits available, because already we are getting, I think the private sector will get the kits in another 7 to 10 days.
Yeah, Dr. Raja is shaking his head. So if the patient is PCR negative, antibody positive,
Yes.
As we pointed out, that's the ideal situation. The patient,
Right, yeah.
I mean, for as I told you, the surgeons would want that particular patient. So I believe he will be also the ideal patient for chemotherapy selection. Except that, I mean, like you pointed out, and what Ullas also points out, what about false negativity and all? I don't think I can answer those kind of variables here.
So I think Dr. Sharmila pointed out that in her hospital, they also found 3 to 4 cases out of 30, 40 tests, you know, who were asymptomatic. So similar experiences emerging from different places. So the another question, and Dr. Kumar wants to say, is on the medical legal aspect. So I think there's a question which has come from the audience that while on treatment, if the patient is tested positive, he or she can say that, you know, while getting treatment at the hospital, he or she contracted the COVID and he's going to sue you. So what are the thoughts there, you know, Dr. Kumar, and whatever you wanted to say, Dr. Kumar, please.
So I had one query for Dr. Mudassir. Which center he got tested? I just wanted to get a hang of
Fortis Noida. Fortis Noida.
So, yeah. Okay, so 2 centers now we have almost 6 to 8% positive asymptomatic patients.
Right.
That, you know, that's a bit, you know.
So your thoughts on the medical legal thing, you know, person acquiring COVID during the treatment of 2, 3, 4 months.
I think so. That is where I do agree that patients can sue us for many reasons. But that's the reason where we need to have ISMPO or some other guidelines which you know, we can fall back upon, and that will make our life a bit easier.
So what we have done is that we have evolved a 2-way consent form, which says that, you know, you can give it to us and we can give it to you. So if you want the treatment, take the risk and kindly sign that consent form. So I think which is fair because I can be an asymptomatic carrier. The relative can be an asymptomatic carrier. So we don't know who is a carrier and who is not. So we can mutually exchange the virus because of this asymptomatic or a silent carrier business. Dr. Raja, yeah.
Discuss this. At least, sir, last time we discussed this, at least there is something to fall back. The IMA has already issued the, consent form that clearly states that just by coming to the hospital, just by wanting to undergo the tests and going through all the procedures and treatment, you will be at a higher risk for COVID infection. Right. So the IMA consent form is available, and for us, every patient whom we see in OPD or IP, we get a consent.
Dr. Purvish, you have, since the medical legal aspect is there, Dr. Purvish would like to comment?
Sure. My interpretation is based on my discussion with medical legal experts, who are doctors and lawyers both. They have said that there is no need for special consent. There is a epidemic act that has been enacted, and under that it gives special, protection to all healthcare professionals. So please don't worry about that. We don't need to take extra consent, and if the patient has filed a case against us, it is his job to prove that he did not get it from somewhere else.
Perfect.
So we should be quite.
So the hospital is not the only place he's visiting.
Correct,
I mean, he's visiting so many other places.
Right.
I think Dr. Anurag Mehta had a comment. I'm told, please make your comment, Dr. Anurag Mehta.
Yeah, Dr. Shyam, actually, I was referring to the antibody test and the PCR together, because we know the PCR has a sensitivity of around, positive predictive accuracy of about 60%. And when we combine it with a antibody, it can rise up to 90%. So we will still miss some cases. And as far as the antibody testing is concerned, it is only when the IgG antibodies have become positive that the patient has gone into the convalescence phase. If it is IgM positive and the PCR is negative, I guess you will have to repeat the PCR. You then cannot say that the IgM antibody is positive and patient is not going through the symptomatic phase.
So anybody who tests PCR positive has to demonstrate PCR negativity before entering into the treatment program. Dr. Mehta, is that?
If he's IgM positive that means he is going through the active phase of infection.
Yeah, IgM positivity, right.
IgM positive.
Yeah.
Only when he is IgG positive, that
Right.
means he has entered into the convalescent phase.
Correct.
We still don't know if he's IgG positive. He is not a virus shedder. So he can still be shedding viruses.
Right.
And therefore, we will need to do a PCR even if he's IgG positive.
Absolutely.
And if he is PCR negative, IgM positive, I guess you will have to repeat the PCR test.
So I think Dr. Prashant Mehta from Asian Faridabad has comments on testing for antibody for healthcare workers particularly, because those are the ones who have been exposed to the virus and are into a convalescent phase. So any thoughts, Randeep, on that issue subject of healthcare workers being pushed to frontline who are antibody positive?
Sir, I think Dr. Anurag Mehta sir has made a very valid point that if you are IgG positive, and recently there has been some papers that such patients are being, I mean, their convalescent plasma has been used for treating the patient. So I think if you are IgG positive, it is a safe thing. Only thing is that whether we do the testing, I think if you have to do a mass testing screening, then rather than doing a PCR, it is better to do an antibody testing. And if you are IgG positive, you are still safe.
Right. So can we move on to the slides? If there are any more questions, I think most of the thought process has been cleared. Next, please. There was something on the SBRT. Next, I think we've discussed these points. Next. So this is the issue, which is the use of stereotactic radiation for brain metastasis. Can it wait? Do we have Sharmila ji and or Dr. Pooja on the panel still?
Yeah. So as far as the brain metastasis is concerned, if the patient is not symptomatic at the moment, we can wait for the radiation to start. We can defer the radiation at the moment. But if the patient is symptomatic, then definitely we can ask the patient to go with palliative radiation therapy. And in order to make the patients visit less to the hospital, we can reduce the number of the fractions also. Like routinely what we are doing in brain metastasis, 30 gray in 10 fraction, we can make it as short as 20 gray in 5 fractions. So that's one of the options possible. SRS, of course, brain metastasis can be done, but then it has to be a very single lesion or 2-3 lesions minimum only, so that we can proceed for the SRS.
Right. So I think because it's a very short course, so I think it can be delivered if somebody is symptomatic. Otherwise, so I think we are coming towards the end of this panel discussion. I think it was quite fruitful. So any final thoughts, Dr. Purvish?
I think you've done a fantastic job, and this is really, the questions are never going to end.
Yeah.
We are already 15 minutes beyond schedule. And for anybody who has still some unanswered questions, please go ahead, and I'll hand over to Prashant Mehta to give his final thoughts and concluding remarks, especially because there could be some reason why Indians are actually protected from the COVID, and therefore we are getting less severe disease. So Prashant, over to you, please.
Hello.
Yeah, we can hear you.
Yeah. Okay. So thank you so much, sir. And first of all, this was just a very enlightening session, and I want to congratulate everybody who has been a part of this discussion, because this is a difficult time, and for everybody to take out time in this stressful phase take out time for this is great, and we have such a great attendance for this webinar. So this is, as we all understand, this is a very, very difficult time. We don't understand this virus. This is a new disease. We hardly know anything about this virus, and we are just getting to understand it. So there are very, very differing opinions amongst people, amongst oncologists also. So I'll just share one small story from my hospital. And this was just about early March in our tumor board. And we had 2 medical oncologists there, and one of the oncologists in our team, he was just very, not very serious about this problem. And we were not expecting that this will escalate to such a level. And he said that Hindi mein ki ye bekar ki baat hai, to ye sab nikal jayega. But with time, this has really escalated, and this has become a huge, huge global issue. And a very good article in NEJM last week by Dr. Mark Lewis, if all of you must have read probably. So he compared this, Hindi mein hum bolte hain kuan aur khai. So ek taraf cancer, and on the one end of the spectrum is COVID-19, and there is a Greek mythology. In Greek mythology, there is these mythical creature called Scylla, and who is a 6-headed monster. And then there is a whirlpool called Charybdis. And this was an article between Scylla and Charybdis deciding for our patients in oncology. So on one hand, on one side we have a 6-headed monster, we have cancer, and on one side we have such a difficult, another difficult problem which has just cropped up now for all of us. And it was already we were facing a huge challenge treating our cancer patients. So yes, this is a huge problem. And in India, we have such a huge burden of cancer. We have such a huge burden of disease. It is even more challenging for all of us. And we already were short on infrastructure. So yes, it is going to be very difficult. And formulating guidelines based on this scarce data we have is again going to be very, very challenging. So Dr. Anurag Mehta and Dr. Shyam Aggarwal were discussing when the therapy should be resumed. So that is extremely difficult to answer because recently, just probably 2-3 days back, there has been a paper on 56 patients, study on PCR, and about 66% of patients still were PCR positive at 3 weeks, and at 4 weeks, about 30-40% patients were still PCR positive. By the end of 6 weeks, these patients were PCR negative, and we don't know whether this PCR positivity actually correlates with transmission. Again, the antibody test, the sensitivity is a problem, but after 7 days, initial 7 days, and while the patient is symptomatic, yes, it is a very handy test. So yes, we are going to come up to some conclusions on using various combinations of antibodies as well as PCR, and probably symptoms or CT scans. We don't know as yet, but yes, I do believe that ISMPO should make it a point to formulate concrete guidelines at this juncture and keep it dynamic, keep modifying it as and when we have more data available. So a lot of questions which came up during this discussion, they were answered and they were discussed. And in the beginning of our webinar, Dr. Hemant Malhotra, he had shared his center experience in his center, the policies they are following at his center. And he suggested that the patients who were symptomatic, or they were coming from hotspots, or they were admitted with complications of cancer, either complication of cancer or complications of chemotherapy, and are hospitalized, they should be tested. And thermal screening and symptomatic screening should be done at the entrance for all patients. And it did sound quite reasonable to me, but I did write a letter, a tweet to PMO and our health minister, that there could be something done for non-COVID hospitals, because from Italy and from US and from Spain, from most of Europe, we have data and we know that hospitals are actually a reservoir for COVID. And this is where the transmission is at its maximum. So if we can control that, and we can designate non-COVID hospitals, which we are doing, and the country is doing very well. Let me tell you that the country, the government is taking all necessary steps. Probably they are looking into the details of what is happening in and around the world, and they are, they are trying to not make those mistakes again in India. They're trying not to repeat those mistakes which Europe has made, and this is a very good thing for our country. So what I thought is, probably this test, the COVID-19, should be done for all patients who are coming to the hospitals, and there should be a consideration for limiting caregivers to the hospital, and also testing the caregivers with a less, probably a less sensitive test, or a cheaper or an easier test. So I had a few points which I wrote, and I thought that probably for everybody coming to the hospital, COVID-19 should be done, and there would be a time that this will be made into a guideline. Probably this is what I can see for the future. Right now, yes, we have limited number of kits. We don't we are short on infrastructure, short on resources. Yes, we need to select today. We need to be very selective. But there will be a time that we'll be testing much more, and we will be testing probably all patients visiting hospital to prevent hospitals from becoming a reservoir for infection. So why do we need to test for everybody coming to a non-COVID hospital?
Slides band kar. Slides band kar.
First, number one, we need to prevent exposure to healthcare workers and these hospitals from becoming silent reservoirs. Silent because we know that 80% of these patients now, they are asymptomatic. So hospitals can be silent reservoirs. And also we want to prevent healthcare worker clusters from landing into quarantine. We don't want that half or 1/3 of our manpower lands up into quarantine at one point of time, and we cannot manage our patient load. There was so much discussion on radiation, continuing chemotherapy, continuing radiation, or doing surgeries, but we are not doing all this alone. We have so many other people, other staff members who are working with us. They are radiation physicists, they are technicians, they are GDAs, they're in the OT, they're OT staff, OT technicians, anesthetists. There is a huge team. If these people are missing, we can't continue therapy. So even if we say that, okay, you have recovered, you want to start with therapy, and when half of your workforce is quarantined, you can't continue therapy. We want to protect healthcare workers, and we want to protect them from being quarantined as well, because they are the manpower and they are going to treat patients. So the next point is we want to reduce the full PPE requirements, because PPE is scarce. We need to make sure that we don't expose everybody to this disease. And because as Dr. Randeep said, in daycare, if you're not testing, the hospital says that treat everybody as COVID positive. If you treat everybody as COVID positive, you're going to need much more PPE. So that is also a huge problem. So probably testing more will make sense in future. So why is PCR? And another point which I missed is we want to protect our families as well. This is also important. As healthcare workers, we are also responsible for our families. When we go home, we don't want to expose them. So if everybody in the hospital is getting tested, we can probably protect our families in a better way. So this is also very important. So why is PCR and antibody test two different things, and why they should be utilized for different purposes? We should be utilizing an antibody test to screen symptomatic patients. We can avoid a PCR there upfront because they are symptomatic. They have gone through the incubation period. They must have developed IgM antibodies, and probably they would be antibody positive. The sensitivity would be probably more than doing a PCR. And not only this, we are going to save money with that. It is a simple blood test. Collecting the sample from nasopharynx is not easy. There are misses, there are sampling errors. So the PCR is 70% sensitive, but because of the sampling errors, the sensitivity goes down even lower. That's why in the first instance, many patients are missed. And in the second sample, you collected probably, that could be a bias there. In the second instance, the sample might have been collected in a better way. So sampling errors are more common. Also, we are exposing our technicians, our healthcare workers, while collecting the sample from nasopharynx, you need PPEs. So we are exposing them more. So in this setting, at least, symptomatic patients, antibody testing may be more prudent. Also for healthcare workers, antibody test sounds wiser because they have a high risk of exposure, they have a high pre-test probability. And also another important point, you will find if any existing immunity is already there. Right now, the world feels that we are not sure. We don't know that there is lasting immunity or not. But biologically, it is very, very plausible and looks like it will follow the pattern for any other virus. The immunity would be long lasting, most likely. So another point that for patients and caregivers who are coming from known hotspots or clusters or containment zones, which the government has set up, we can actually utilize the antibody test because again, there is a high pretest probability and also it will be cheaper and more cost effective because you're doing it for a large number of people. PCR should be utilized for asymptomatic patients always. In asymptomatic patients, let's say you're taking up a patient in the operation theater and you want to operate him, PCR is the test to do. Yes, there the antibody test should not be utilized. For asymptomatic caregivers, this is an interesting point. For asymptomatic caregivers who are accompanying the patient, We don't know how far they've traveled, where all they have been. They are traveling with the patient. They are also a source of infection. So for them, the numbers would be large. So for this cohort, doing the antibody test may be a reasonable alternative. So all this is for the future, and probably we may be developing more guidelines as to how to utilize all these tests. And I do believe that with time, these testing strategies will improve, and we would get better, more sensitive tests also. So, and cheaper tests, and easy to do tests. So this would become probably easier. So this is regarding the testing. So my thoughts on where we are right now. Regarding continuation of chemotherapy or immunotherapy or targeted therapy, and there was a thought on ibrutinib as well. So right now, the most of the oncologists, most people, they feel that chemotherapy would not be probably safe to continue if somebody is COVID positive. So there, as Dr. Randeep also mentioned, he said that he is going to hold it. So which sounds reasonable as of now. We don't understand this disease as well as of now. Immunotherapy, there has been a lot of discussion on immunotherapy, whether actually immunotherapy can improve the cytokine storm or the immune storm which happens in the course of COVID-19. We are still not sure, because immunotherapy may be actually a double-edged sword. It may actually worsen it as well by arming our immune cells more. So ibrutinib, there was a thought, probably Dr. Govind mentioned, it actually works on the BCR signaling and through CD79A, which is also a key regulator from where the ACE receptor is connected, and from there it can actually affect its immunosuppressive effect during the cytokine storm. So all these drugs are Jakafi, ruxolitinib, and all these immunosuppressive, tocilizumab, all these are actually being discussed, and we still don't know whether immunotherapy actually will actually help or not. So immunotherapy and chemotherapy, probably we are probably what the present understanding is that we should be holding it. The targeted therapy, I am not sure as of now, but yes, if the patient is asymptomatic, if somebody continues, probably Dr. Kumar Prabhash can throw some more light on that. I am not sure about that, but yes, as of now, if somebody continues, it would be probably okay. So if there are any more questions, I would like all our audience to ask, and probably I can direct the questions to our experts. And Purvish sir, if you have some thoughts on what I discussed and what went through in the webinar, I would like to speak out your perspective. Thank you.
So thank you very much, Prashant. I think those concluding remarks were very good. Most of the questions have already been answered. One question that is still remaining is from Dr. Harita. Should prophylactic hydroxychloroquine be used for healthcare workers who are treating, looking after cancer patients? So Prashant, what are your thoughts on that?
So this is a very, very complex question right now. And when I first read about chloroquine, hydroxychloroquine being used, and the initial preclinical data on the RNA load coming down from Professor Didier Rolt, and I actually was impressed by whatever data was, it was not a very well done study, but yes, I read some immunology after that and virology after that. I understood that it could actually again be a double-edged sword. So yes, it is actually an immunosuppressive drug. It does suppress the Th2 response. So it is again a double-edged sword. ICMR has given guidelines on use of hydroxychloroquine, but still there is a lot of debate, and I would say this is one question which has divided the world into two halves completely. And right now there is no clear answer. If somebody wants to take, I would say that it is still your personal choice. So if some healthcare worker is taking it as per the ICMR recommendations, it is his or her personal choice. I cannot say yes or no to this as of now. And even if I take it, I would take it only out of my personal choice. But yes, I would add a word of caution that it is an immunosuppressive drug. It may be working just because it might be suppressing that immune storm in some patients, but still no clear answer. And there is no randomized data There is a lot of observational data. There is observational data for a cohort of more than 500 patients as well, but it is all single arm and observational. So we need to wait. It might be useful, but it did not work for chikungunya. In chikungunya, hydroxychloroquine was thought of as a drug, same mechanism, but when there was a randomized study, it failed to show benefit. So I think we need to hold on to that question.
Wonderful. Thank you very much. Now it's 2 minutes past 9 o'clock. So we have actually been 2 hours on the webinar, exceeded by almost half an hour. And that is only there because there are so many questions and unanswered and so many experts available to answer these questions. So I think that it's time that we stop. I would like to thank all the faculty for their wonderful insights into the disease and the management. I'd like to thank all the participants and of course thank AstraZeneca and Intas for supporting this educational activity. If there is any question that is still remaining, please email it and we will circulate among the faculty and then give you an email reply. But I think we will have to stop now because I'm feeling hungry and I need to have some dinner. Shyam, thank you very much. You did a fantastic job and everybody else as well. Thank you so much. Manoj from Intas, I can see if you have any comments at the end, we would like to hear that. Kashish, can you? Thank you.
I just wanted to say we are trying to do our bit for ensuring production across the country. I have another few meetings to go just to make sure that all your patients are taken well care of. And it is not just Intas, but the entire industry which is behind you to make sure that wherever you need us, we are there with you. Thank you.
Thank you very much. And I say close the meeting. Please be in touch and then we'll try and push ISMPO to come out with guidelines about for chemotherapy patients at least. So all those who can volunteer to help ISMPO in doing that, please send an email to Dr. Govind Babu and we'll take it forward from there. Thank you very much.